Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. I am also the medical author of the book Focused Neurology. My email is sreeklpm@gmail.com. Today we are going to talk about a very interesting topic, Cognitive Neurology Part 1, Frontal Lobe. Cognitive Neurology Part 1, Frontal Lobe. So today we are going to discuss all the important frontal lobe functions. So frontal lobe, there are basically four lobes: frontal lobe, parietal lobe, temporal lobe and occipital lobe. Today we are going to discuss frontal lobe functions. History of cerebral localization. Certain areas of the cerebral cortex have specific functions. For example, Broca's aphasic patient 1861 demonstrated that speech functions were localized to the left inferior frontal gyrus. Huggins-Jackson was the first to point out that there is a motor cortex. Cerebral lateralization. The hemisphere to which a function is lateralized is said to be dominant for that function. Left hemisphere is dominant for speech function and right hemisphere is dominant for spatial function. So left hemisphere is dominant for speech function and right hemisphere is dominant for spatial function. So nature has beautifully divided the functions of speech to left hemisphere and function of the spatial orientation to right hemisphere. For most of the right-handers, the language areas are situated on the left side and therefore left cortex is called as a dominant cortex. Generally we call a cortex as a dominant cortex when the speech centers are situated on that particular cortex. So for most of the right-handers, more than 90% of the right-handers, the speech areas are situated on the left side, what we call it as a dominant cortex. Human beings owe their commanding position in the animal world to two faculties. We owe a commanding position in the animal kingdom because of the two important faculties. One is the language and intelligence. Second is the manual dexterity, the way we use our fingers. In fact, the representation of the usage of fingers, that is the motor homunculus in the brain, is the largest. We have the largest representation for fingers. So by these two faculties, one the language and intelligence, second is manual dexterity, human beings owe their commanding position in the animal world. Frontal lobes. The frontal lobes are often conceived to be the human being's supreme evolutionary attainment, especially the prefrontal lobes. You are an individual identity. You have your own uniqueness. You are is because of the frontal lobes. You are what you are is because of the frontal lobes. Your thinking, your abstract thinking, your foresight, everything resides in the prefrontal lobe. So the frontal lobes are often conceived to be the human being's supreme evolutionary attainment. The frontal lobes lie anterior to the central sulcus and superior to the sylvian fissure. Blood is supplied to the medial parts of the frontal lobes by the anterior cerebral artery and to the convexity by the superior division of the middle cerebral artery. The underlying deep white matter is supplied by the lenticulostriate arteries of the middle cerebral artery. The clinically important areas of the frontal lobe include the motor strip, which is concerned with the movements, the premotor and supplementary motor areas, The prefrontal region, as I said, it is the most well developed in the human beings, and our intelligence, planning, everything lies in the prefrontal region. We have the frontal eye fields, which allows us to deviate the eyes to the opposite side, and then we have the motor speech area, the Broca's area. So these are the 5 important areas in the frontal lobes. The frontal lobe lies anterior to the premotor area, is referred to as the prefrontal cortex. So here in this diagram you can see the frontal lobe. It is anterior to the central gyrus and superior to the sylvian fissure. So this is the frontal lobe. The prefrontal area, the portions of the frontal lobe anterior to area 6 and area 8 and the motor speech centers are areas referred to as the prefrontal cortex. The prefrontal cortex is the main projection site for the dorsomedial nucleus of the thalamus. It receives dopaminergic fibers and are associated with attention, short-term memory, reward, planning and drive. Clinically, the prefrontal region can be divided into dorsolateral prefrontal cortex, the medial prefrontal cortex and the orbitofrontal cortex. These brain areas are highly developed in humans, and they have long been considered the seat of higher intellectual functions. The tale of Mr. Phineas Gage. Much of the information about the functions of the frontal association areas has come from the examination of Mr. Phineas Gage, a 25-year-old railroad worker who sustained severe damage to his frontal lobes when a metal tamping rod was blasted through his head after a freak accident. So when Mr. Phineas Gage was working near the rail tracks, a rod went and pierced the frontal lobes, and that's how he developed all the manifestations of frontal lobe dysfunction. So according to Mr. Harlow, who was closely associated with Mr. Phineas Gage, he was no longer Gage. The Gage before the accident, the behavior of the Mr. Phineas Gage before the accident and the behavior of Mr. Phineas Gage after the accident was totally different. He reportedly became irreverent, lacking respect, profane, not respectful of religious practices, impatient and unable to hold a job, and died 13 years later. The prefrontal area, the dorsolateral prefrontal cortex. The dorsolateral prefrontal cortex is important in the organization of self-ordered tasks, working memory and executive functions. Executive function is the ability to plan, carry out and monitor a series of actions intended to accomplish a goal. In fact, if this particular area gets affected, they cannot perform a movement in a sequential manner. They will be out of sequence, which is known as ideational apraxia. The prefrontal region plays a role to predict the consequences of actions, emotional expression, go-no-go decision making, personality, sense of time and thinking. The ventrolateral prefrontal cortex is concerned with mnemonic processing of objects. The medial prefrontal cortex is important in auditory and visual associations. The orbitofrontal cortex has important connections with the limbic system, including the amygdala. Amygdala is the organ which is responsible for the memory of fear. We are afraid of our superiors, we are afraid of others because of amygdala. In fact, some amount of fear should be there so that you will be disciplined and work well. If the amygdala is removed, the memory of fear is lost. This was elegantly demonstrated by Kluwer and Juicy, who removed amygdala of monkeys. Generally, monkeys are very friendly with snakes. Generally monkeys are antagonistic to snakes. They are very hostile. But the moment the amygdala was removed, the monkeys became very friendly with the snakes. In fact, they took the snakes, put around their necks and started playing with the snakes. This goes to show that the amygdala is very important for memory of fear. Disinhibition syndromes ranging from mildly inappropriate social behavior to fully blown mania may occur with dysfunction of orbitofrontal cortex, particularly of the right hemisphere. Frontal lobe dysfunction. At the age of 35, a previously healthy patient, EVR, underwent removal of a large orbitofrontal meningioma. Although surgical recovery was uneventful, his behavior, judgment and social interactions were forever impaired. He collected outdated and useless items. So, because of Mr. EVR, we could know about the functions of the orbitofrontal cortex. So, goal behavior according to Luria 1973, there are 4 steps. Goal related behavior: specification of a problem, formulation of a plan initiated in an orderly sequence, execution, comparing the results against the original plans. Dominant hemisphere apraxia. Apraxia is an inability to perform a learned motor act despite motor, sensory, coordination and comprehension being normal. There are basically 3 types of apraxia: ideational apraxia, idiomotor apraxia and kinetic limb apraxia, which are seen predominantly in the dominant hemisphere. We have other 2 apraxias, dressing apraxia and constructional apraxia, which are seen in the non-dominant hemisphere, but they are basically to do with the spatial orientation. So what is ideational apraxia? Ideational apraxia, the orderly sequence is affected. The lesion is in the SMA. SMA areas are crucial for the temporal organization of multiple movements to perform a movement in a sequential manner. In persons whose frontal lobe, especially SMA, gets affected, they cannot perform a movement in a sequential manner. For example, when they are asked to brush the teeth, they may take the brush, start brushing and then take the brush out and then they may put the paste. So they perform action which is out of sequence, and therefore activities of daily living are impaired in ideational apraxia. Even with real object, they are not able to perform a motor act in a sequential manner, and therefore activities of daily living are impaired. In idiomotor apraxia, it's like a disconnection syndrome. There may be a disconnection between the language centers that understand the command and the motor areas that are tasked with carrying it out. So the planning of the movement with the actual execution of the movement, there's a disconnection. So they are able to perform with the real object, but when they are asked to plan, imagine and then perform, they can't. Imagination of an act cannot be done, but with the real object, the act can be performed. So if you ask them to show the act of smoking, they find it very difficult. They cannot take the hand, imagine as if there's a cigarette and then smoke. But when the person is given a real cigarette, he's able to take it out and smoke well. So imagination is affected, but with the real object, they are able to perform the act. Since with the real object, they are able to perform the act, activities of daily living are not affected in idiomotor apraxia. And fortunately, idiomotor apraxia is more common. Since activities of daily living are not affected, the patient is not even aware that he's got idiomotor apraxia. It is a doctor who examines and then picks up the complaint. Whereas in ideational apraxia, activities of daily living are impaired, and therefore the patient himself comes up with the complaint. And then we have the third apraxia, which is to do with the limb movements, kinetic limb apraxia. The natural kinetic melody or smoothness of transition from one hand position to the next is disrupted, and there's a tendency to perseverate. As I said, There are other two types of apraxia, dressing apraxia and constructional apraxia. They are in the non-dominant hemisphere, but they are basically to do with the disturbances in spatial orientation. How do we check dressing apraxia? He is not able to put on the trouser well. Instead of putting it on the right, he may put it on the left. Or if he is asked to construct a particular diagram, he is not able to construct the diagram. Yeah, the prefrontal area, the main area for intelligence and the highly developed area, especially in humans. Abulia. It refers to difficulty in initiating and sustaining spontaneous movements and reduction in emotional responsiveness, spontaneous speech and social interaction. It is characteristic of frontal lobe and basal ganglia lesions. Akinetic mutism. It is an extensive bilateral prefrontal lesions which may culminate in akinetic mutism, a state of persistent unresponsiveness. Emotional lability may be prominent. Yeah, now we'll go to the other areas. The motor cortex. The motor area of the frontal lobe include the primary motor cortex area 4 as well as the premotor and supplementary motor areas. The motor cortex contains the large motor neuron, that is the bed cells in the layer 5, that gives rise to corticospinal and corticobulbar tracts. Involvement of area 4, that is the motor cortex, causes hemiplegia. So motor cortex, if it gets affected, person will have hemiplegia on the opposite side because corticospinal tract descends and crosses at the level of the medulla oblongata and goes to the opposite side. The premotor cortex. The premotor cortex lies just anterior to the primary cortex, squeezed between the precentral gyrus and the posterior border of the prefrontal area, area number 6. It is involved in the planning and execution of movements, particularly the sequence of the movements. Supplementary motor area. They are crucial for the temporal organization of multiple movements. The supplementary motor area also coordinates movements between the hands, and lesion in this area may cause the alien hand syndrome. It is like something like sympathetic apraxia and Broca's aphasia, a more severe form. For example, if there is a lesion in the left frontal area, they will have paralysis of the right hand, and in the non-paralytic left hand, there will be a continuous movement which is not under their control, which is known as alien hand syndrome. It is because the information to the right frontal area which is necessary does not come from the left frontal area because of the lesion, and therefore since the left frontal area gets affected, they will have right paralysis. But since the right frontal cortex is intact, there is no paralysis, but because the information is not coming from the left frontal area to the right frontal area because of the lesion, the hand does not seem to be under their control, which is known as alien hand syndrome. And lesions of the more anterior and medial parts of the motor cortex causes less paralysis and more spasticity, and may allow the emergence of primitive reflexes such as grasping and groping responses. These primitive reflexes, that such as grasping, groping responses, avoiding, sucking, all these reflexes are present during our infancy. Perhaps they are necessary for drinking milk and other activities. But once the frontal and parietal lobe starts maturing, around 1 year or so, all these reflexes diminish, which conveys the impression that the frontal and parietal lobes are matured. If the frontal lobes are not matured, there is a continuation of these primitive reflexes beyond infancy. Or at the other end of the spectrum, the frontal lobes may mature, the primitive reflexes disappear, but at a later point of time, disease may affect the frontal lobe. Again, it may get affected, and there may be re-emergence of the primitive reflexes. So persistence of the primitive reflexes or disappearance and then re-emergence of the primitive reflexes indicates that the frontal lobe either is not matured in the first place or has matured but then at a later point of time has been affected with the disease. The SMA functions in planning motor movements such as a sequence of actions provided from memory. The frontal eye fields. The frontal eye fields lie in the middle frontal gyrus and control movement of the eyes to the contralateral side. These are known as frontal eye fields area number 8. So the frontal eye fields area number 8 are stimulated, the eyes goes to the opposite side. These are known as saccadic movements. So when the frontal lobe is affected, it cannot push the eyes to the opposite side. So eyes will be looking towards the side of lesion, but hemiplegia will be on the opposite side because the corticospinal tract descends from the frontal lobe at the level of the medulla, crosses over to the opposite side. So eyes looking to one side and hemiplegia on the opposite side is a frontal lobe lesion. If it's a pontine lesion, the PPRF has got a tendency to pull the eyes towards each side. So if the PPRF gets affected, it cannot pull the eyes towards each side. Eyes go to the opposite side. Hemiplegia is also on the opposite side. So eyes looking towards the side of hemiplegia is a pontine lesion. Eyes looking to one side and hemiplegia on the opposite side is a frontal lobe lesion. And not only eyes look to one side, even the head is also turned to the side of the lesion with hemiplegia on the opposite side. Why head is also turned to the same side as that of the lesion? Because frontal cortex controls ipsilateral sternocleidomastoid muscle, and therefore when the frontal cortex gets affected, the ipsilateral sternocleidomastoid gets affected. So the opposite sternocleidomastoid will take over, so it pushes the head towards the opposite side. So frontal lobe lesion, eyes is shifted to the side of the lesion, head is turned to the side of the lesion, but hemiplegia is on the opposite side. So destructive lesions in this area cause gaze deviation ipsilaterally, whereas epileptiform activity causes gaze deviation contralaterally. These are all destructive lesions. If it is a stimulatory lesion of the frontal eye fields area number 8, it pushes the eyes to the opposite side, it stimulates the sternocleidomastoid, head also turns to the opposite side. So eyes turning to one side, head turning to the one side. It is a frontal lobe seizure. Seizure originating from the frontal lobe, known as versive seizures. The motor speech area. Broca's area lies in the inferior frontal gyrus anterior to the motor strip. Lesion in this area causes Broca's aphasia. Basically, we have three components of the speech. One, comprehension, which goes to Wernicke's area and tries to understand a person's speech. Then repetition, that is the arcuate fasciculus, which connects the Wernicke's area to the Broca's area. It conveys the message, so it is important for repetition. And third is the fluency, that is the Broca's area. So the word output, generally the normal word output is 100 to 115 words per minute. In Broca's aphasia, it may be reduced to as much as 10 to 15 words per minute. So Broca's aphasia, Wernicke's area is intact, so they can understand. Arcuate fasciculus may be intact, so repetition also may be intact, but Broca's area is affected, so they cannot speak. So non-fluent but sensible speech is Broca's aphasia. It's a telegraphic speech and they have hemiplegia on the opposite side. Bladder and gait disturbances. Lesions of the frontal lobe may also cause incontinence, particularly with the involvement of the paracentral lobule. We have the bladder area, leg area and the medial part of the frontal lobe. So if the medial part of the frontal lobe gets affected, the leg area gets affected, so they'll have problems with the gait. The bladder area gets affected, so they'll have problem with the urination. So gait disorders, magnetic gait may also be seen. So they may be able to cycle on the bed, pedal with the legs on the bed, but when they are actually asked to perform the act of walking, they can't do, which is known as magnetic gait. Seizures in frontal lobe disorders. There are basically three types of seizures in frontal lobe disorders. SMA causing a particular type of seizure disorder, orbitofrontal cortex causing a particular type of speech seizure disorder, and dorsolateral prefrontal cortex causing a certain type of a seizure disorder. So SMA causing seizures. Seizures arising from SMA often involves tonic posturing, that is either unilateral or asymmetric and often accompanied by facial grimacing and automatisms, as well as vocal symptoms such as laughing or speech arrest. So they have tonic posturing. Orbitofrontal cortex. Seizures arising from the orbitofrontal cortex often involves pedaling, thrashing movements, easily confused with pseudo seizures. So there will be usually movement with the legs. So persons may mistake it to be as pseudo seizures. Dorsolateral prefrontal cortex. Seizures arising from DLPFC, dorsolateral prefrontal cortex, are often adversive with the turning of the head and eyes to the contralateral side, which I just mentioned. Turning of the head because of the ipsilateral stimulation of the sternocleidomastoid, so they turn the head, and frontal eye fields area number 8 gets stimulated, so eyes also go to the opposite side, which are known as adversive seizures. Yeah, so far I've discussed all the important functions of the frontal lobe. Now let me summarize the manifestations of frontal lobe dysfunction. So what are the actions of the frontal lobe, functions of the frontal lobe, and what are the effects of damage in the cognitive behavioral sphere, associated physical science sphere, and positive phenomenon sphere? So the functions of the frontal lobe are: 1. Personality, emotional control, social behavior, contralateral motor control, language, and maturation. The effects of damage which are seen in the cognitive and behavioral sphere are disinhibition, lack of initiation, antisocial behavior, impaired memory, expressive dysphasia, and incontinence. The associated physical signs seen when frontal lobes are damaged are impaired smell, contralateral hemiparesis, and frontal release signs. And the positive phenomenon seen with the effects of damage are seizures and versive head movements. Yeah, these are all the important concepts of the frontal lobe functions and the dysfunction of the frontal lobe. Most of the important points of neurology, I put it in a question answer format in a book called Focused Neurology, where I am the author, Dr. Sreenivas. It is available online from all leading booksellers. You can buy it online from Amazon if you are interested. So these are the important concepts of frontal lobe function and dysfunction. I hope you have enjoyed listening to my talk as much as I have enjoyed delivering it. If you have any suggestions or comments, kindly post onto my YouTube channel, but please like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, and my web page, Dr. Sreenivas Concepts. Thank you. Bye.